Diagnosis of a DA in a cow is usually accomplished by anybody with a little bit of experience. There's a tympanic resonance that you can hear usually along a line from the wing of the ilium to the xiphoid, and then 10 to 15 centimeters on either side of that line. Usually it's heard or ausculted best in the paralumbar fossa, as delineated by this triangle. Most times we can even, in a really distended one, see the faint outline of it just behind the last rib here. If you auscult between the last few ribs, usually you'll hear a pretty classic resonance. It sounds like it's variously described as a rubber kickball. If you want to ballot the abdomen, you can hear a very classic sloshing, and this particular animal has exactly that. If you auscult and you hear you need to do a differential, you can go ahead and hear, in some rarer instances, by ausculting the transverse process of the wing of the ilium, you can hear sometimes ringing on a few DAs that are really grossly distended. But we usually differentiate between left displaced abomasum and ruminal atony based on whether or not the cow rings when we hit her on the wing of the ilium. And then of course there's the characteristic sloshing, and usually after you've ballotted the abdomen and you hear this slosh, you can hear gas bubbles come up through the abomasal liquor. Process, or the advantage of being able to do a toggle suture repair of left displaced abomasum, is that it's fairly brief in terms of time that it takes to go ahead and do so. And in this case we have a halter on the animal. We've done a dual half hitch, or what's called a sideline, in order to be able to cast the animal. And then we have some leg ropes that we're going to go ahead and place on this animal on her front feet as well as her back feet once we have her in dorsal recumbency. We're going to cast her to her right side. We're going to roll her into dorsal recumbency, tie our legs back so that she's safe and so anybody assisting us doesn't get hurt. We're going to identify our landmarks, we're going to repair the DA, and then we're going to go ahead and let her rise. It's up to the discretion of the person doing the repair as to how much, if any, sedation needs to be used. In most instances it isn't necessary except for a refractory or an unusually large animal. It's difficult to do so. A couple things I'd like to point out in this particular facility. Notice that the bedding here, there's a nice deep manure pack here, so that if you have an animal who's very thin, it's not uncomfortable or painful for her to be in dorsal recumbency. The other thing that's important to remember is that when you have a nice soft bedded pack like this, is that she has better footing and is able to go ahead and get up. It's helpful if you have a gate system like we have here, so that we can put a cow up behind it and hold her in position, so when we do lay her down, get her into dorsal recumbency, it's much easier to keep her position rather than having her move about the pen. So those are all some considerations. We also like to have a pen with adequate room in it, and usually one or two people are required for assistance so that we can go ahead and get the animal safely and easily. We're lucky in that our demonstration animal today happens to have fairly small stature, so she, in theory, should be easier to get on her back. Actually, you can use that one, can't you? One of the things we like to do is give the cow enough halter room so that when we lay her down, we have enough room to roll her over with some degree of ease. So you ready? We're going to go ahead and pull on the sideline, cast her, and we put somebody on the head to hold her. Some people like to tie both rear legs separately. I prefer the separate. Some people like to go ahead and put both legs together. some immovable object. In this case, a nice sturdy stanchion. Roll the rest of it. So now we have our dorsal recumbency. I'm going to tie her just a little bit more lateral. Keep her stable. Eric, could you hand me that, please? Notice that I had to go get my pail, but a lot of times, since you can't predict just where the cow's going to lie down, it's good to have it out of the way where it can't be spilled or damaged. Our landmarks are the end of the xiphoid process, the midline, and we want to be just to the right of midline. So we're about 10 to 15 centimeters caudal to the end of the xiphoid, and then on the right lateral side to it, and about 10 centimeters lateral to midline. You notice that we have this cow now where she can't kick any of my assistants, and most importantly, she can't kick me, selfishly. I usually like to clip or scrub with some povidone, betadine solution, clean the operative area. And then to leave my landmarks so that I know where they are, I go put my thumb on the end of the xiphoid process, and I take betadine solution, povidone solution, and just identify. So now I know in a moment, just looking, where the end of the xiphoid process is. Then I take the toggle suture, trocard, and cannula, put it in the base of the handle. Always make sure that the push rod is inserted fully down the lumen of the needle because it gives it greater strength and stability. Place it between your index and middle finger and butt it up against the palm of the hand. It's fairly ergonomic this way. This next step is really quite important in terms of successfully perforating the abomasum, and it's to put some weight on the abdomen just ahead of the udder. And I usually put all my weight on there, and you can actually see her bulge up. So I've identified about 15 centimeters posterior to the end of the xiphoid, now lateral about 8 to 10, and you can sculpt and hear the same sound. In this case it's really very loud, just like it was when we were listening to her earlier, diagnosing her. So we're going to go ahead and perforate quickly. Identify the characteristic odor of the gas. Place the suture in, push rod, and push it clear down. And then lightly jig it, make sure you don't cut it. Make sure that the toggle has turned sideways inside the lumen. Bring it back up. Pull it fully tight and clamp it like that. Reattach your needle to the handle. Put the push rod in. That was your posterior most suture. Now you're going to move the anterior to it. Weight on the abdomen again, moving the anterior and perforating. That gas. Place the second suture. Now at this point it's important to get as much gas out as you can. That goes ahead and puts less tension on your sutures. It also helps to go ahead and make sure that you have less leakage around your suture itself. So you can see fluid here. If you collect this fluid. Naturally, I didn't bring my pH meter. I have it, but I didn't bring it. You can see the fluid. And you get down to the fluid, and if you're unsure at all as to whether or not you're in the abomasum, you can check the pH, and the pH should be between 2 and 4. At this point, again, you're just going to lightly pull on this, remove the trocar and cannula, and clamp it so that it's tight. Now you know that the abomasum is right tight against the abdominal wall. And many times, some people like to put a stint on, and you can place it based on how far apart you put the sutures. On this particular farm, they don't care to have a stint on, so we want to go ahead and tie a square knot with a distance underneath of about 3 to 4 centimeters from the knot itself to the skin wall. I'm going to put your hand there, Chris, for me. Thank you. So you can draw it down like this and put your first knot on. Thank you. Tie it, and because this is aramid fiber and it's relatively slippery, we like to go ahead and put a number of knots on. Then when I'm done, usually we'll go ahead and pull it tight. Cut the sutures and roll her on overclockwise. At this point, any follow-up medication in some cases has already been given. Sometimes we go ahead and give follow-up medication, long-acting beta-lactam antibiotics. We release the animal. We also treat for any concurrent conditions such as ketosis, arthritis, what have you. In this case, on this dairy, this cow's already been medicated ahead of the procedure. And that's it. So we're going to pull her over onto the bedding here, so she has footing to get up. She rolls up, and she's able to walk off none the worse for wear. I'm sure most of you have flown on a commercial aircraft, and if you've ever noticed that pilots, if it happens to be a clear day and you have a visual view of the aircraft, most commercial pilots will do a walk around and check all the control surfaces of their airplane. That very same principle applies to any surgeon taking a look at their equipment before they do a procedure. And one of the things that we always recommend doing ahead of this procedure are just checking to make sure that the toggles don't have any potential for failure. So putting the toggles between your fingers like this as if they were in the abomasum and giving them a pull lets you, if there should for any reason be a failure, now's the time to have it, not when you have the cow on her back, tranquilized, and the help there to go ahead and do it. So a reasonable pull on that tells you that your sutures are okay. You can see that there's nothing wrong with them. There's no fraying. There's no problem with the suture, and these work then very well. They are made of plastic and they're designed to break. It's very painful for me to go ahead and get them wrapped hard enough to go ahead and pull, but I'm going to demonstrate one breaking. If I pull really hard, it's supposed to break. But that's much more desirable than having some very rigid structure, say made of steel or some other immobile substance, and then tearing a hole through the abomasum and leaving a 3-centimeter hole through, which you know is going to result in fatal peritonitis. So they are made of plastic for a specific reason, and the reason is because when the suture pressure gets too great, they're supposed to break. And that's a point that's important to remember. They're not supposed to hold under any circumstance, and they break at around, they're supposed to break between 20 and 25 pounds of pull. This suture trocar cannula is designed to be like a Swiss Army knife. Everything is supposed to go ahead and fit together so it doesn't get lost. This is the push rod, and you want to be sure that the end is not too sharp, that it's relatively smooth. And the other important thing is that the needle itself be kept quite sharp. I made reference to lightly jigging the needle, but as you can see, or jigging the suture once it's in the abomasum. But as you can see, the sides of this are relatively sharp, so if you pull too hard, it's possible to go ahead and cut the suture. So it should be a light jigging of the suture. So we've gone ahead and we've placed the suture in the lumen of the abomasum, and you can see how it's supposed to turn sideways like this. If you pull too hard, you can see it's possible to go ahead and cut it on the sharp edge of the needle. So lightly jigging it, as I showed, like this, so you can actually hear it when it's in the lumen of the abomasum, and you can feel it moving very freely both down and back. If it were not turned sideways and were like this, you can see that the suture just kinks on itself. But if it's free in the lumen of the abomasum, the suture material goes freely down the lumen of the cannula. And again, it's important when this trocar and cannula and push rod are all assembled that that push rod be placed inside the lumen of the cannula, because it gives strength to the actual overall assembly, and it's much harder to go ahead and bend it if that push rod is in the center. And like any metal, if it goes through enough cycles, eventually it can be broken. But I've used these on thousands of cows, and they've stood up remarkably well. Periodically, it's wise to sharpen just the very point of that needle so that it goes ahead and perforates the skin. Remember that most DA cows are relatively dehydrated, and therefore their skin is more like old shoe leather than it is that of a nice healthy animal. So it's important to keep your needle sharp. And the other thing that I would advise anybody perforating the abdominal wall is that the thrust is very fast and very quick. It's not a slowly push it through. You're not only going through skin and muscle and fascia, peritoneum, you're also going through abomasal wall, which may or may not be quite distended and inflated. And so it's necessary to go ahead and make that thrust very quick in order to ensure that your suture makes it into the lumen of the abomasum. The other thing that's important to go ahead and note is that you notice that when I do this procedure, I'm handling it with my hands rather than worrying about maintaining absolutely sterile technique. You'll notice that it's put in a sanitizing solution of iodine, and you need to remember that this suture is going to penetrate the lumen of the abomasum, which is not at all sterile. You're putting a hole in the abomasal wall that's about 3 millimeters in diameter, 4.5 millimeters actually in diameter, and so there's going to be some leakage of abomasal contents. So even if you were completely sterile placing the suture in, there's going to be some leakage, so your sterility is ruined by the very nature of the procedure itself. So for those who might be concerned that that's an issue, not to be too concerned. One other device that I use and was going to demonstrate in our toggle method is a handheld pH meter. It's very useful if there's any question in your mind as to whether or not you actually have perforated the abomasum. The one thing I would say, as a result of our study, I discovered that I thought I could always get a pH sample from the abomasum, but in probably a good 50% of the cases, I'm unable to obtain any fluid from the abomasum when I'm emptying it after placing the last suture in. But I'll demonstrate that pH meter as well. This is a CardiTwin pH meter. It's available from Spectrum Technologies, and their phone number is 800-248-8873. pH meters are exceedingly useful for many things in veterinary practice. It's easy to go ahead and calibrate this particular pH meter ahead of utilizing it. You take a pH 7 standard solution, hit calibrate, and it'll list itself as calibrate here, and I think you can see the 7.0, and then you'll get a smiley face down here, and that means that it's calibrated. And very quickly, if you get just a drop or two of abomasal fluid, you can tell from the pH. And I've actually cut a couple of sutures that for whatever reason didn't manage to make it into the abomasum, but clearly were in the lumen of the rumen because the rumen pH was 6.2. So you know you can't possibly be in the abomasum if the pH is that high. The other thing I might add, it's surprising how many pHs are actually at 1 or slightly below 1 much lower than I've read them to be in in most textbook references in terms of normal physiology. I should address one other thing that has to do with these sutures in and what they do in the abdominal cavity. Once they've been in the lumen of the abomasum, you do in fact have some small amount of leakage around there, and you get hopefully just a small amount of localized peritonitis and resultant adhesions. It is not terribly unusual after a long period of time to see a suture, a toggle, actually hanging free outside the abdominal cavity, outside the skin. I've taken any number of pictures of them. The cow's doing perfectly okay, eating and acting perfectly normal. What's happened, for whatever reason, it has worked its way back out, and there's still a stalk of adhesion that goes ahead and holds that abomasum in place. Some people like to cut their sutures after, regardless of surgery or toggling. It's my philosophy that unless they appear to be causing any kind of problems, that we almost always leave them in until they either go away or disappear, or somebody gets tired of looking at them and they go ahead and elect to cut them. So again, it's a prerogative of the individual who's doing the repair as to whether or not the sutures are cut after an appropriate period of time when an adhesion can have formed to hold that abomasum to the lower right quadrant of the abdominal cavity.